Okay, with that, let's move on to Theresa. And as Mental Health America's Chief Program Officer and Vice President of Research and Innovation, Theresa Nguyen manages MHA's programs, including the MHA screening, where over 1 million individuals a year seek mental health support for the first time. As a licensed clinical social worker, she advocates and researches strategies to build a consumer-based mental health workforce, to improve access to treatment through digital supports, and uses data to bring underserved communities. She currently teaches at University of California Irvine's Advanced Immigrant Rights Clinic and at California State Fullerton's Department of Social Work. Theresa is currently a board member of Project Return Peer Support Network, the U.S. Olympic and Paralympic Committee Mental Health Task Force, the Mental Health Research Network Advisory Committee, and is a Patient-Centered Outcomes Research Institute ambassador. So Theresa, excited to hear what you're going to share today.
Hey, everyone. Okay, so I just want to start with sharing a little bit about who MHA is. We're basically the mental health version of the American Heart Association, but our roots and our history is grounded in protecting the rights of individuals who live with mental health conditions. I found MHA early on in my career, and I fell in love with its mission and its work because I come from a family, a long history of diagnosed and undiagnosed mental health challenges stemming from anxiety and alcoholism all the way up to psychosis and schizophrenia. I personally also struggle with depression and complex PTSD, and a lot of a lot of the personal experiences that we have as a community shape the way that we see equity issues. Certainly, historically, the mental health community is not a stranger to what institutions do to people who don't have a voice, to take care of the things that we need to do are not necessarily centered, right? And things have not necessarily changed. We know this, that we used to have large state hospitals, and there continue to be large state hospitals where people get lost into, and we continued that practice all the way into the institutions that we continue to use today, much in many ways for profit. So what I want to share today is a series of work that we have developed as a response to understanding the importance of taking a race equity and an anti-racism lens on our work in mental health. Because many of our projects span across the country, and because MHA screening is free and available to all people, and the work that we create actually is global. We do see that 10% of our users actually come from across the entire world. I think that this year, if anything, highlights the true importance that our systems are not bent towards fairness. They are not bent towards race equity or kindness. And that it's really our responsibility as a team, right? A number of people have to come together to make this commitment, to make sure that the products that we create are done right. We really have reflected on why. I used to say, like, is this a question? Can we trust ourselves given centuries of programming? And now I'm like, no, fairly solidly, I think that it is absolutely true that we cannot be trusted given centuries of programming. And when I say programming, it is because that is what it feels like. It feels like I, as a brain, as a computer, have been inputted information since I was born towards a white-centric community. I cannot undo this. And so the only way to start is to be aware of what inputs are put in and then set up what we understand are safeguards. An example that I think in the broad scope, not a specific programmatic scope, which I will go through, is around language, for example, right? In mental health, we often think about words that are used for us, like stigma is the one that we often don't like because it's so ambiguous. It doesn't really allow for the system itself to say, well, what is stigma? What does that mean? Is it fear? Is it discrimination? And who is the one that has power to create fear and discrimination for a person who has a mental health condition or who is Black? So I think that for systems, we have to use examples. We have to call them out, and then we have to battle them. And so what I've listed here, and I am really heartened because this has been a product of months of work for our teams at MHA to think about this process. And obviously we cannot trust our blind spot. We fully acknowledge that we have more blind spots than we may be aware of. And so this process is to build safeguards for checks and balances for our own content and our own programs to make sure that we are taking an anti-racist and race equity lens. That's weird. So overall, the 4 questions that I'm going to address today are we being inclusive? Are we representative? Are we being responsive to the needs of the people that we're serving? Are we making sustainable and systemic change? And are we harming communities? So I'm going to go through this and give you examples of what we see. So inclusivity and representation is interesting because I would say from the mental health community and the disability community, we often know what it feels like to be left out of systems that are built for us. And then they put these systems on us and wonder why they don't necessarily work. So, it's who is included and who is left out. If you don't ask who is left out, you often assume that who you've included is all the people that you should have included. Some of the things I think are really interesting are intersectional views. So when you think about an intersectional approach, are there certain populations that are important to include? I love that Lee talked about face recognition, right? Something that we often think about is that as technology grows and AI grows, and you think about face recognition software that might even support work issues. This is a broad issue. But if you don't think, for example, to bring in a trauma lens into this, where we know that with mental health challenges, if I'm having an episode or if I have intergenerational trauma, this affects my affect, my ability for my face to show certain features. And does that make coding a particular face recognition that might be, for example, tied to productivity a problem? Like, has a company taken that perspective into account when they think about what inputs they put into a computer? I also think that I put the resource here on mixed race, and it's not just one box, because one of the things that as we've analyzed some of our research on who is left out or how data is used to view people, I think in healthcare data, one of the most interesting factors is that when you go to the doctor and you say, well, I'm Black or I'm Asian, for people who are mixed race, this is the most complicated issue. And in a lot of the data that we've started to see with researchers, people will say, well, we're going to set across these entire protocols in healthcare. But, we have this bucket of data where it's like not answered or other race. And we're just like, well, we don't know what that is. So and a little bit of the pushback is, it's not okay to say, well, we just don't know what that is, or somebody did not answer. Because honestly, I think if you are intentional about the way that you're inclusive or representative, you look at your data and you ask yourself, does the other box or the missing data represent a community where institutional challenges are present? So, for example, is that an overrepresentative sample of mixed race individuals where we know poor outcomes are faced by these individuals? Is an example of the importance of asking these questions. And then I have heard across the last 2 days a really important factor, which is how are we engaging people? What roles do they play, and where are they involved? Are they involved only at the approval end, where we see a lot of people tokenize a variety of communities where, we're asked to be on an advisory board, but it's only once something is published and just to give a stamp of approval? Or are people involved from the get-go? Are we paying equity by making sure that we have Black researchers and people with disabilities who are thinking about these issues because they live and breathe them and they're involved from the beginning to the end, right? So next moment. You can create a product and it can be inclusive and representative, but it's important then that the product that you create is responsive. And this is because we know that once you create systems, because of our blind spots, you can almost guarantee that there's something that you will miss, right? And so we ask ourselves, like, does what we create work for people? Is there evidence that shows that it's working for people? When I start to look at my data and the feedback from my data, I need to make sure that I have an opportunity for people to give anonymous feedback. And if I'm able to look for what populations are being left out based on the data that I'm receiving, I think it's really important. Does it reach the people that you intend to serve? If you've created a product for people and you can see that it is not reaching that population, I think it's important from the earlier standpoint to kind of go back and say something has been seriously wrong, maybe because we did not include the right people from the get-go in the development. And then be responsive to change your work based on the feedback, based on the data you receive. An example that I think is really interesting is that we hear a lot about, as I said, fear of and discrimination and systems not working for communities all across the board, and in the Black community, certainly. But what we found that was interesting and a new piece of data we did not anticipate from our screening data, which is now over 6.5 million pieces of data across the country, across multiple years, is that time and time again, Black communities, Black screeners tell us that more than any other race, ethnicity, this group says they actually do want immediate support through the phone. And by a long shot, which I think is so interesting. So what that tells me is that I get afraid that as a system, we've used the excuse of fear or stigma to justify why we have not systemically invested in local Black-led community services for Black communities. And if you look at the data, if you look at where services are provided, you will see that that's absolutely true. And that is a systemic problem. That's a responsibility for us to respond to and to create, right? But I think that if you just looked at the narrative and you ended just on fear or discrimination, it's just too easy. It's too easy to fall into traps. Wendy was interested in having me share some specific data on COVID on NMHA's site, and I'm happy to share a link. We've been collecting an enormous amount of data, even just starting COVID. And what we did absolutely see since COVID started was that the number of people who came to screen and the severity of how sick people were has increased exponentially. I just want to put a chart in here for psychosis because I think we expected depression and anxiety to rise, but we did not. But honestly, screening increased across the board for all people. And when you see the numbers of the data, certainly that's not separated from maybe our own effort to reach people and make sure that they are getting help that they need. So, one of the questions we're asking is, can I trust this data? And does this say something about COVID itself, or does this say something about MHA? And so at least for us, looking at rates of rise was also an indicative factor of the importance of what's happening specifically during this time in terms of stress to our communities and what this means, right? So we saw the rise in both the number of actual screens that people took, huge jump, but more alarming was the number or percentage of individuals who screen at risk for the issue. So back before COVID, the average screen percentile risk was at 66%, which is still pretty high. But as we've moved and people have experienced more stress, we're concerned that more and more people are possibly having the kind of stress that can trigger a first episode of psychosis, for example. So 76% of individuals who take a psychosis screen now score positive for early ultra high risk psychosis. We have broken down this data by race. And what I think is interesting about this space is something that we've asked ourselves when we evaluate data is it true Can I trust what the data is saying? And is it important, or what is important? And this piece of trend has existed across multiple years. And so when you see consistency across time, it does make us feel more confident that something is true. But and then what is important is our next step, right? And we do find that it is interesting that if you look at the two populations, you see groupings. So when you think about self-harm or suicide, we see one grouping among Latinos and Black Americans and white Americans as having suicidal thoughts nearly every day at about 35%. And then there is a slight gap where there's a grouping among, again, other, which was like weird. Who is the other? What might they identify as? American Indian population who consistently screens more severe and speaks out about some of their intergenerational trauma. And then more than one race. Again, this was a data point that popped out for us where we were like, something is happening for multi-race, mixed race individuals, and we need to understand or unpack what that is. And then Asians. Again, also don't know what that is or what that's about, but that question of why is it important and what is important here to understand is what we're trying to unpack. And I threw this slide in because we've been asking about COVID stress specifically, and it's really not surprising that Black Americans are concerned about finances, given systemic oppression. And that American Indians are reporting more past trauma. I had a conversation yesterday with the Indian Health Board, and they were like not surprised, but also just glad to hear that someone else was aware that trauma was a huge issue for American Indians, and that Latinos were more worried about COVID-19, which again, not surprising given what we know about the higher risks for essential workers in the Latino communities where they are going out and working every day and in sometimes closed quarters. So I just put this in case it piques someone's interest. Our next question that we ask is about sustainable and systemic change. And I think that this is the most important question that we can ask ourselves to make change for good and to be creating a society that we want to live in. To do this well, you have to ask what the legacy or history of discrimination is that exists in your system. How are we as a system perpetuating or being complicit in that system? Is what we are making helping to make existing systems less racist? This is important. I need to create information, data that helps me create some material change that is real and not performative, right? One area of work that I think is so interesting that we started to talk about is deconstruction and reconstruction. So a talking point I think we've heard is like, do we start over? Do we rebuild? Do we have to find something new? And honestly, for us, the answer is yes. It is quite possible that the only way to go forward the right way is to absolutely deconstruct, which will take time, but it took 400 years to create the system we have today. So we need to start, and we need to start sooner than later because we're already too late at deconstructing so that we can reconstruct. And the two will happen simultaneously. And then the next question are there power structures or disparities that are inequitable? Like, is what I created possibly perpetuating inequity? So I'm just going to share an example of what that looks like for us, right? So in some of our research, we've asked people what kind of help do you want next? We had some assumptions because the way that we realized, like, everybody in our team years ago said, well, when we ask this question, I'm pretty sure that everybody's going to want to go to therapy or see a doctor. And very quickly, once we put the data out, the answer was obviously not. People did not want to go see a therapist. In fact, 50% of people did not want to go seek traditional mental health system services. And what we see overwhelmingly for impacted communities is that our healthcare system consistently fails communities. And so for us as a calling from MHA was that it really truly was a need to democratize care. That means get the care into the hands of people who have more control and more power over their care rather than forcing them into the systems that we have. A version of what we're doing is our project with Microsoft and Northwestern and University of Toronto. We're doing some large-scale studies on text messaging supports to help people get started in this early pathway. A lot of it is adaptive messaging. We want to make sure that young people get the help they want. We know that most people have a serious delay in access to mental health treatment that can be anywhere from 2 years for psychosis all the way to 10 years for PTSD or anxiety issues. And again, because the systems are failing us in therapy and in hospitals, this is using the technology that's right at your hand. And if it's adaptable to you and your need and is inclusive, this may, at least is our hope, one of the best ways to start that conversation for an individual, because it's a safe space, right? Your own phone, you opt into the controls, you answer if you don't want to, it is anonymous, it has the option to bring you to community and groups online if that is what you want. Otherwise, you continue to organize yourself in this self-engaged pace until you feel ready to engage. And when you are, we're there to help you guide that process and find a therapist that is culturally responsive and hopefully has done some significant work in being anti-racist, right? Then harm to others. And this is interesting for us because I think from a trauma perspective, the mental health disability community has experienced so much harm when we're pulled into institutions that make us feel out of control, that we're incredibly sensitive and sometimes emotionally reactive when it comes to protocols that sweep you up. So we have to ask, is there any way that what we're doing could make something worse for someone? And I think the most important thing is that second question. Will I choose to abandon a process or pause it if harm is present, right? And so an example in mental health that's easy is that we know that for a long time, as part of the red box, if you said that you felt suicidal, was that we would tell people to call 911 or go to an emergency room, which is awful. We know what the problems were around that. But what else was wrong was also just the ER. Like for people who are Black who go to the ER, the system doesn't appear to be an unsafe situation, but how many ERs do you go to that don't have security guards who are armed, right? This is part of what we understand is systemic racism and systemic racist policies that are created that people didn't question for purposes of safety, right? Safety for who, to protect who from whom, right? So just no more. Across the board, we're like not sending anybody to the police, telling people to maybe not even actively tell people to not call 911 and maybe not even go to the ER. We looked at crisis text line. We worked with the National Suicide Prevention Lifeline, tried to identify our best attempt at anti-racist policies to help people of color, Black communities specifically, on finding a safer alternative to crisis care. And in the end, I'll end with a voice of hope for change. In the mental health community, we think about recovery and what it means to get better and feel better from trauma, from addiction, from pain, from mental illness. And what I love about this frame is that it is hard work and it is hard to unpack even my own blind spots and the way it runs up with my own trauma and how it brings a lot of these feelings up. But I want to create this system because doing so, it is rooted in hope. hope is what I think will save us. I think hope is what we need in 2020. I also feel like we need power. We need to empower people and to give people actual power towards self-determination, to find the care and get the care they want. And the other final beautiful thing about this is that when you answer and work on hard questions, you do them in community to build community. And this makes me heartened because I have met the most incredible people. I continue to meet people who inspire me to fight the good fight. This leads us towards how doing the hard work of anti-racism is such a high risk for burnout. Anti-racism and disability rights work, working for oppressed people is hard work. And we talk a lot about burnout and talk about self-care. Because self-care, as the Black Panthers said, was a social justice issue. We need to take care of ourselves to be in the long game, to fight the systems that have been built for other purposes, like capitalism, for example. So that is the end of me, and I hope I ended on time.
You did.
I didn't even have.
You did perfect. Yes.
Okay.
Yes. Thank you, Theresa. I thank you for that message of hope too. So good. And I just want to say, we hear a lot about the school to prison pipeline, but the hospital bed to prison pipeline is something you mentioned that I think needs more light on that.
Absolutely. Anytime we think of institutions that exist, I think we need to be heightened in our understanding of how institutions are not bent towards equity, fairness, or kindness. They are not. And so if you want to be responsive, you have to be, then you go like, do we even use these systems? Do we need to deconstruct and reconstruct these systems? Yeah. There's some, I don't know, I'm sure my Black people on this call have like a gut. We think of the trauma in the gut, and I know that they can just pull out all the list of institutional systems instinctually that are bent towards pain and harm. But for us, non-Black people, like, we have work to do.
Absolutely.
We have a lot of work to do. Because at least, I think about yesterday and that white spectrum, like, I have been programmed and I can be white passing, and it is absolutely my responsibility to be aware of that. Yeah.
Yep. Absolutely. Yeah. Well, I want to thank you so much. And what we're going to do next, we're going to hold all the questions for our three presenters until after Ahi speaks. Just we're moving we got some moving parts today. And so, Theresa, I just want to thank you, and we'll ask some more questions later.